Good evening, all of you. We'll just wait for 2 minutes and then start with the session. Okay, so good evening, all of you. Welcome to recall session of NEET MDS 2024 of subject oral medicine radiology. Okay, so all of you have given your NEET MDS 2024 paper. I hope it was good and we can expect good results. Okay, so let us start with the first question for the OMR. Okay. Question 1. WHO in London 2005 renamed pre-malignant and precancerous lesions into which of these terms? So basically, before proposing the name, it was named as a pre-malignant lesions and pre-malignant conditions, right? Then in 2005, WHO proposed that they should be named as a one term. Okay, they should be named as a one term. Which is that one term? It is potentially malignant disorders. Okay, potentially malignant disorders. So what should be your answer is option A. Okay, you can write down in the comments. Okay, whatever answer you have marked, you can write it down in the comments. Okay, and if you have any doubts, you can put it in the comments. Okay, moving on to the next question. Okay, it was image based question and the image was given of ameloblastoma. Okay, they had mentioned that the ameloblastoma, the radiographic image of ameloblastoma is given, and what they had asked was these are the septae within the pathology. So they gave the multilocular lesion, okay, and they were asking about these septae within the pathology that are giving the multilocular appearance. What is the cause of these septa? Okay, the septa which you see, okay, say if you have this multilocular lesion within the body of the mandible, okay, and these are the multilocularity and the septas that divides this locules, okay. What are these septa? These are basically a residual bone, okay, residual bone which is remained after destruction of bone by the pathology. Okay, so among the given option that we have formation of new bone within the pathology, entrapment of normal bone within the pathology, deposits of dead bone within the pathology, and D was fractured bone within the pathology. So The correct answer should be entrapment of normal bone within the pathology. Option B should be your answer. Okay. So, multilocular appearance basically comes due to the residual bone that remains after destruction of the normal bone. Okay. So, your answer should be option B. Okay. Moving on further, we have the example of stochastic effects. Okay, so the examples of they have given the options within which we have to choose which of the following is the stochastic effect. Option A is radiation induced cancer, skin cancer, B is skin burns, C is osteoradionecrosis, and D is cataract. So, those who have attended my lecture, I have shown this table. Okay, this the flow chart. Okay, and in that they have like clearly mentioned the deterministic effect and stochastic effect. If you have gone through this chart also, you would be able to rule out the options which are false. Okay, so deterministic effect includes the xerostomia, osteoradionecrosis, cataracts, and decreased fetal development. And stochastic effect are basically what? Stochastic effects. Stochastic effects are basically sublethal, okay, changes in the DNA of individual cells. So they are sublethal changes, okay, individual cells. And the most important consequence of this stochastic effect is what? The most important consequence, okay, of the stochastic effect, okay, is carcinogenesis. Carcinogenesis. This is the direct like statement given in the textbook. Okay, so the most important consequence is the carcinogenesis. And among the given options, we have first option B directly refers to the carcinogenesis, which is radiation induced skin cancer. Okay, so the example of stochastic effect is option A. Option C and D are deterministic effect, and option B also comes under deterministic effect. Even if you don't know, even if you get confused between option A and B, if you know what are the stochastic effect and what are the consequences of it, then you would be able to answer this question. Okay, so the option A is the correct answer. All right, moving on further. Okay, this is very easy. This is like a scoring question, I would say. Okay, question fifth: subcondylar fracture can be best viewed in which radiograph? The options were Waters view, reverse Towns view, jug handle view, and OPG. Okay, what should be the correct answer? It's the direct question. Option B, reverse Towns. Reverse Towns are used for subcondylar or high condylar neck fracture. Okay, high condylar neck fracture. Okay, so yeah, you all are giving me the options. Okay, the okay, so basically I want to tell you that these are the recall, like we have collected it from the students. Okay, so any options here and there, please consider it. Okay, I am giving you the basic idea of the question and what should be the answer of it. Okay. Yeah. So reverse Towns is the ideal radiograph for subcondylar fracture or high condylar neck fracture. All right. There are only four, you can say, the conventional radiograph that are used for TMJ view. We have transpharyngeal, we have transorbital, we have transcranial, and we have reverse terms. Okay, but among these, transorbital is used for this, you know, right? Transorbital is used for medial or lateral displacement of condylar fractured segment, right? All right. Then we have transcranial, right? Transcranial. Now these are the ideal conditions in which you will refer these radiographs that you should know. Okay. So high condyle fracture question we have. Okay. Transorbital is used for this condition. Transcranial is used for medial, I'm sorry, lateral aspect of condyle. Transcranial is used to view lateral aspect of condyle. And we have transpharyngeal. Transpharyngeal view is used to view medial aspect of condyle, right? Medial aspect of condyle. Okay, so these are the basic, you can say, radiograph they can ask in next year exam also. And here we have already in 2024 exam, we have already one question based on this, right? Okay. Uh, Question 6. A 13 years old patient presents with multiple sinuses, okay, and matted lymph nodes. Okay, what can be the cause of the same? So they have given a patient, 13-year-old patient, we have multiple sinuses and we also have matted lymph nodes. Okay, what do you think should be the answer? Now here, many of you get confused between option A and B, that is tuberculosis and actinomycosis. Okay, because sinuses, multiple sinuses, we usually see in these two conditions, right? And more specifically, we have heard that actinomycosis is the one which uh, can cause these multiple sinuses, multiple draining sinuses, and the sulfur granules and all that, right? But they have also mentioned matted lymph nodes. Okay, so here we have the twist. Matted lymph nodes are seen in mycobacterial infections, right? Second one, we see that in sarcoidosis. These are benign conditions, right? Benign, okay, or the infections and benign conditions. And in the like a malignancy, if you consider malignancy, in which condition we see matted lymph nodes, we have lymphoma and metastatic carcinoma, right? Okay. So, in malignant condition, lymphoma, metastatic carcinoma can show matted lymph nodes, and in like benign conditions or infection, mycobacterial infections and sarcoidosis shows this matted lymph nodes. Okay, and the correct answer for this is option A, which is TB, because many of you must have or might have got confused between this actinomycosis and tuberculosis. But since they have mentioned matted lymph nodes, the answer is TB. Okay. And you all should know what is matted lymph node. Matted lymph nodes are basically group of lymph nodes that feels connected. When you palpate the lymph nodes, you feel that it is a one unit, okay, one mass only. Okay, so here the example I have just put up the image to just show you the example of it. Okay, so these are basically submandibular lymph nodes. Okay, submandibular lymph nodes, you can clearly see these two lymph nodes. Okay, but when you palpate it, you can just feel it that there is one mass only. Okay, and the unit, it will move as a unit. Okay, so that is called as matted lymph nodes, and the conditions that I told you, these limited lymph nodes are seen in those conditions. Okay, and I've just put up this USG image also. Okay, you can see this multiple lymph nodes conglomerated as a unit, and here there is MRI also. Okay, here MRI section. All right. Okay. And also in actinomycosis, if you ask me, lymph node involvement, it is rare. Okay, lymph node involvement is rarely seen, but if it is present, okay, then the matted lymph nodes is not a condition in actinomycosis. Okay, all right. Okay. Seventh question we have, they have just given the radiograph and they have asked to identify the lesion. And the radiograph was like a radiopaque mass, and there is an impacted tooth beneath the radiopaque mass. Okay. And the options were option A, ameloblastoma, option B, odontoma, option C, ossifying fibroma, option D, osteoid osteoma. All right. So the clear answer, very easy. Okay. Posterior mandible is the location. Impacted tooth, you can clearly see the impacted tooth over here. Okay. And the radiopaque mass is irregular. Okay. And what should be the answer? Option B, odontome. And if they would have given the types of odontome also, you would have easily guessed the answer. It is a complex odontome. Okay, it is a complex odontome. Complex odontome. Okay, posterior mandible is the location associated with impacted tooth, right? Irregular radiopaque mass, right? All are the features of this complex odontome. Okay, there were other options also, ossifying fibroma. Ossifying fibroma, if you get confused between this ossifying fibroma and odontome, ossifying fibroma is basically fibro-osseous lesion. Okay, and usually it is well defined. Okay, well defined because the growth is equal in all direction. Okay, and at the periphery of ossifying fibroma, you would have seen the radiolucent, like thin radiolucent line. Okay, because this ossifying fibroma shows three stages. First is radiolucent, second is mixed, which is radiopaque and radiolucent, and finally, radio opacity is more at the center, and the surrounding is the radiolucent rim. Okay, because it contains calcification, so the inner mass gets calcified. Okay, calcified. All right. And the growth is concentric outward direction. Okay, is seen. Osteoma, we are not sure that if the options were there. Okay, osteoid osteoma is basically benign tumor, and it is extremely rare in jaws. Okay, and it is common in cortex of limbs. Okay, it affects cortical bone of limbs. Okay, and if it in case it occurs in jaws, mostly affects body of the mandible. Okay, but here there is no case of we cannot consider this as a osteoid osteoma. All right, so clear answer option B, odontome, which is a complex odontome. Okay, all right. A 19-year-old girl shows a horizontal impacted third molar tooth in the mandible. There is radiolucency of 1.5 to 2 mm around the crown of the tooth. Identify the condition. And the options were dental follicle, dentigerous cyst, ameloblastoma, and radicular cyst. What do you think? What should be the answer? You can put it in the comments. What do you think? What should be the answer? Anybody? Very easy question. Okay, these are the all the OMR question I thought was very scoring. Yeah, somebody MDS army. Yes. Okay. Good. Most of you have answered correctly. So, dental follicle, if you have the impact or erupting tooth, okay, erupting tooth or impacted tooth, okay, and around that we have this follicle, sorry, the radiolucency, and they are telling it is of 1.5, okay, 1.5 to 2 mm, right? 1.5 to 2 mm. So when you have given the radiolucency of this diameter, it is basically a normal follicle, okay? Normal follicle, okay? The hyperplastic follicle is say less than 5 mm, less than 5 mm. Okay, so you can consider it from 2 to 5 mm. Okay, 2 to 5 mm is the hyperplastic follicle. But if it increases greater than 5 mm, then it would be considered as, or it is qualified as a dentigerous cyst or cyst. All right. So this is basically the correct option is option A. Okay, because they have clearly mentioned the size of the radiolucency. This is directly pointing towards the follicle, okay, normal follicle. All right. Okay, moving on further. Op- Question 9. A young girl presented with a mandibular swelling, right? You see there is an anterior mandibular swelling with buccal cortex expansion. All right. CT shows multilocular radiolucency. All right. And on aspiration, only few drops of blood is seen. What is your provisional diagnosis? You can post it in the comments if you know the answer or if you have marked it correctly. Let's see how many of you have marked correctly. Okay. One answer. Okay. Yeah, good. Most of you have answered correctly. It is CGCG. Option A is correct. Okay, because what are the main, you can say, presenting signs of this CGCG? Okay, first of all, mention of anterior mandible. Okay, because the epicenter of CGCG is anterior to first molar, right? Epicenter is anterior to first molar, right? Okay. Multilocular radiolucency, of course. Multilocular radiolucency is seen, right? And on aspiration, few drops of blood. So histopathology or histologic features of this CGCG, what it contains is the fibroblast, numerous vascular channels, right? And these numerous vascular channels was responsible for few drops of blood, right? And of course, multinucleated giant cells. Multinucleated giant cells. Okay. So, yeah, so we got our correct answer is CGCG. Okay, and on radiograph for the future reference or the students who are going to give the next year's exam, yeah, this is the appearance what you see, and the feature radiographic feature is wispy septa. So VSP septa is also seen in this CGCG. So just remember the features of CGCG. All right. And they might give you a question, and they might give you two condition, hyperparathyroidism and CGCG. Okay, and they might confuse you giving the features of these two, because the features of these two are very similar, but the you can say the differentiating point is the PTH, right? Parathyroid hormone, calcium and phosphate levels. All right, so you need to differentiate these two conditions. All right. Okay, so all right. Yeah. So we were managed to get these questions, right? And I thought it was very easy. Direct questions was asked from OMR. Okay, before concluding the session, I would like you to go through this, the latest plan that we have launched, which is Advanced Plus version 2 plan. Okay, and pre-bookings are open now. These plan consist of pre-recorded videos of 600 plus hours, okay, of high quality and of all the 19 subjects. All right. And also contains extensive question bank, or consist of 20,000 plus exam relevant high yield questions. All right. And we also have competitive test series, subject wise, image based GTs, okay, and multiple mock and mini tests also. We also are involving this clinical world of 40 plus hours, okay, and the special focus will be on the patient and doctor interaction, okay. Then we'll be providing hard copy notes also, which is carefully crafted and high quality, time stamped from the recorded videos. All right, and we also have revision videos for all the 19 subjects with 160 hours, okay, uh, of duration. And with that, you also will be getting daily mentorship by Dr. Himani, okay, which is our oral surgery guru. So yeah, you can pass this message to the students who are going to give next year's, like 2025 MDS exams, okay. And yeah, if you have any doubts, you can post it in our Telegram groups in the comments. Okay. And yeah, we are happy to answer your queries. Okay. So thank you and bye. If you have any doubts, you can post it in the comments. I'll be happy to clear those doubts.